All right, so good afternoon, and thank you very much for the introduction. So my name is Carmine Rossi, and today I'll be presenting some results from an ongoing study entitled The Real-World Effectiveness of Interferon-Free All-Oral Direct-Acting Antivirals in the Setting of Hepatitis C and HIV Co-Infection. All right, so to provide a little background on the topic, so as we all know, due to shared routes of transmission, namely but not limited to injection drug use, HCV co-infection is prevalent among people living with HIV. In low incidence settings, it's estimated that as many as 1 in 4 people living with HIV are chronically infected with hepatitis C, and in Canada, this amounts to somewhere between 14 and 16,000 Canadians living with both viruses. So a sustained virological response, or SVR, to HCV treatment has been strongly associated with a reduction in liver-related morbidity and mortality among people living with HIV. However, in the interferon era, suboptimal treatment effectiveness and low uptake has resulted in pretty much little impact on the HCV-related disease burden. With the introduction of interferon-free all-oral direct-acting antivirals, there's been renewed optimism for HCV elimination in difficult to treat, particularly in difficult to treat populations, including people living with HIV. In fact, clinical trials of selected HIV populations have reported cure rates in excess of 95%, but these studies have largely excluded people who inject drugs, so PWIDs, patients with chronic comorbidities, or those who had drug-drug interactions with other HIV medications, which are all conditions that are very prevalent among people living with HIV. In fact, there's little real-world data on DAA treatment effectiveness and its predictors among HIV Hep C co-infected individuals receiving clinical care. So the objective of the current study was to assess socio-demographic and clinical characteristics associated with treatment failure of all oral DAAs among co-infected patients in a real-world clinical setting. So I'll go over our study methodology very quickly. So data from for the study comes from the Canadian Co-Infection Cohort, or the CCC for short. So the CCC is an ongoing multi-center prospective cohort study, which since 2003 has recruited nearly 1,800 co-infected patients from 18 study sites in 6 Canadian provinces. The cohort is largely representative of the co-infected population in Canada, and study participants complete biannual study questionnaires that provide information on self-reported demographic and substance abuse information, chronic comorbidities, and as well as hepatitis C and HIV treatments. And study nurses also obtain laboratory measurements for CD4 cell counts, viral loads, and HIV and hep C viral loads. So for patient selection, we sought to identify all patients who initiated interferon-free all-oral DAAs between November 2013 and July 2017. We applied the following exclusion criteria. We excluded patients who were treated with DAAs through a clinical trial, as these patients would not meet our target population. We also excluded patients who were treatment experienced with DAAs prior to enrollment in the co-infection cohort because they would not provide any prospectively measured data prior to them initiating DAAs. And lastly, we also excluded patients who were previously successfully treated with interferon-based regimens and then subsequently got reinfected before being treated with DAAs. We felt that these patients would likely already do better with DAAs given they had already run through a difficult 24 to 48-week course of pegylated interferon-based therapy. For our outcome, we define HCV treatment failure as either an end-of-treatment non-response, relapse, premature discontinuation, or death prior to achieving SVR12. So for our study covariates, we extracted the following demographic, behavioral, clinical, and HCV-related information. For demographic, we considered age, sex, and indigenous ethnicity. For behavioral, we obtained information on current injection drug use, so that was injection drug use in the last 6 months, as well as current problematic alcohol use, which we define using the Audit-C questionnaire, as well as history of depression. For clinical covariates, we considered CD4 cell count, HIV viral load, hypertension, diabetes, and kidney disease. And HCV-related variables we considered were cirrhosis, their previous interferon treatment experience, their HCV RNA level, and their HCV genotype. And so for our statistical analysis, we compared SVR and treatment failure rates by study covariates using an intention-to-treat approach, and we employed a binomial method to calculate 95% confidence intervals for SVR rates, and we used chi-square or Fisher's exact test as appropriate to test for statistical significance. So I will now go over our study results. So this shows our study participant flowchart. First, we identified 350 patients who initiated therapy with all oral DAAs. We excluded 32 who were treated in trials, 7 who were DAA experienced prior to enrollment, and 9 who were successfully treated with interferon-based therapy before being reinfected and initiating therapy with DAAs. So that left us with 302 patients in our population, and we further excluded 43 who were still missing their SVR status, mostly because they were still undergoing therapy or are still waiting to have their SVR12 response. So this left us with 259 patients in our analytical sample. So this shows our baseline study characteristics. I won't go through it all, but I'll just highlight some key points. So the cohort was mostly consisted of middle-aged men, so median age of 52, 76% were male. Substance abuse was prevalent in the cohort. 17% reported injection drug use in the last 6 months before initiating therapy with DAAs. 22% reported hazardous alcohol consumption using the Audit C-score. All patients were on antiretroviral therapy with a median CD4 cell count of 490, and 7% were still viremic. And for comorbidities, they range between 10% for mildly reduced kidney function to up to 42% for depression. So this table shows our characteristics of HCV treatment-related factors. So for the most part, just like the HCV monoinfected population, most were genotype 1. 65% were treatment naive. 68% had no existing liver disease, and the distribution of HCV viral load was roughly 50% were over 800,000 IUs per ml, where the other 50% were less than 800,000 per ml, and we didn't have information on. Oh no, that's incorrect. Okay, I will skip that one. Sorry. So this figure shows, this slide shows the overall SVR rate as well as reasons for failure. So of the 259 patients, 237 developed an intention to treat SVR result, with the remainder 22 experiencing failure. So for the most common reason for failure was non-response. 17 of the 22 experienced non-response. 3 patients died. 1 had premature discontinuation, and 1 had an episode of relapse. So for reasons of death, of the 3 patients who died, 2 of them actually achieved an end-of-treatment response, but they subsequently died of end-stage liver disease. 1 patient did not have a measured EOT response and subsequently died of cardiovascular disease. So this figure shows our main overall SVR rates by demographic and clinical characteristics. So with respect to demographic characteristics, regardless if the patients were older or younger, indigenous or non-indigenous, SVR rates were over 90%. Females fared better than males. About 10 percentage points higher was the SVR rate for males compared to females. With regards to detectable HIV viremia, those who had detectable HIV viremia had significantly lower SVR rates than those who were virologically suppressed. And with regards to comorbidities, patients who had mildly reduced kidney function, so that's eGFR less than 60 milliliters per minute, had significantly lower SVR rates than those who had normal, I'd say normal eGFR. With regards to behavioral and HCV-related characteristics, SVR rates were elevated amongst those who were using active injection drug use, or who had problematic alcohol consumption, or who had depression. Rates were slightly lower amongst those who had cirrhosis or end-stage liver disease or were treatment experienced, just as in the HCV monoinfected population. With regards to genotype, there were such small numbers that it was difficult to evaluate the difference in SVR rates by genotype. With regards to HCV RNA, both patients who had high HCV viral loads and those who had low viral loads experienced elevated rates of SVR. So I'll now highlight some of our main study findings. So overall, we saw that there were low rates of treatment failures in the real-world population who were treated with DAAs. So our intention to treat SVR rate was approximately 92%. Our observed rates were lower than that were seen in clinical trials, namely because our co-infect population contained patients with additional comorbidities such as end-stage liver disease, chronic kidney disease, or were not virologically suppressed. Our results were largely consistent with that seen in a larger hepatitis C and HIV co-infected cohort in Spain, which also reported SVR rates of 92%. This study also found that male sex and ESLD were associated with treatment failure, and they also found, which we did not see, that immunosuppression was associated with treatment failure. And within this study, we're actually doing future work to examine the role of the specific DA regimen and whether it was suitable for that patient, and examine the impact of treatment as well as the demographic characteristics on SVR rates. Premature discontinuation in this cohort was rarely observed, suggesting that the therapy was well tolerated. Furthermore, treatment was equally affected among substance users and those who had mental health disorders, suggesting that HCV elimination is still possible within these high-risk groups. And lastly, we observed low SVR rates among patients treated with cirrhosis. This is particularly important for the HIV co-infected population because these patients have liver disease that progresses a lot faster than the HCV mono-infected population. So this highlights the need to initiate treatment prior to the onset of cirrhosis and liver fibrosis. So with that, I just want to acknowledge the other PIs in the cohort, as well as my supervisor, Dr. Klein, and as well as the study nurses, and of course also the patients who take time to fill out these questionnaires. Without them, the study would not be possible. So thank you very much.
Thank you, Carmine, for the excellent paper. So I just want to ask a question, first of all. So did you collect and do you collect data in terms of adherence? And if you have those data, how you collect them? And if you saw any impact of the adherence on your results?
Okay, so adherence is a question that's in our hepatitis C information flow sheet, but because it's not filled out consistently by all the study sites, some sites that send in these flow sheets every week will answer the question on adherence every week, but those who only send it once at the end of 12 weeks, then they'll only have that information once. So it's not the same for everybody. As a proxy for adherence, I think HIV viral, whether they're viremic or not, could be a proxy for how they're adherent to their medication. So if they're not adherent to their HIV medication, they're likely to have blimps in HIV viral load, and this might be that the fact that those who are not adherent, it's a proxy for having a low detectable HIV RNA.
So did you see any change in terms of this?
Yeah, so those who have detectable HIV RNA have lower rates of SVR. So this could be a proxy for adherence.
A proxy for it.
Yes.
Dr. Wademeyer.
So it's a great cohort, but you still have 8% non-responding patients. What are you doing with them?
So yeah, they would have to be retreated eventually in the future.
But are you retreating them already?
I'm not a clinician, so I don't know what's happening to them. But I could look it up in the data, but I'm not sure if they've been retreated. Again, they've only failed now recently between the last couple of years, so we don't know if they've been retreated or not.
Yeah, Janssen, Toronto. So beautiful study. Congratulations, really. I was wondering, what is your HCC incidence here? Because this is an interesting population with a fair amount of cirrhotics, HIV infected. You follow them over 4 years.
Right.
This whole discussion that Heiner went to on as well. So do you have data on that?
We do have information on hepatocellular carcinoma rates, but for this specific study, I did not extract that information, so I don't know what the rate of HCC is after treatment failure or whether they're treated as well. It would be probably a next step in our study.
Any other question for Carmine? So we move to the next paper.
Thank you.
Thank you, Carmine.